patients ventilated, and
nothing else.
Okay. and friends. Welcome to another episode of Myome Uveitis wiki-knowledge. This episode is number 6, and it will be about infectious uveitis. So today we will have with me in the panels, I will be honored to have Dr. Iman, Professor Iman Abdul Latif. She's a lecturer of ophthalmology, Alexandria University, uveitis consultant, Egypt. Thanks, Dr. Iman, for being with us and accepting our invitation. All the times, a pleasure to have you with us. Also, Dr. Tariq Siddiqui. Thank you, Dr. Dr. Tariq Siddiqui, actually, he apologized. He have some issue, so we hope that you can see him, inshallah, in the other webinars. The first part of the session, it will be presented by my dear friends, Dr. Mandeep. He's an FRCS, FACS, specialist ophthalmologist, pediatric surgeon, and head of retinal service, Prime Healthcare Group, which have a very successful work and inshallah in his new place.
Thank you, Dr.
And our also dear friends, and what we call, she is very young. Okay, you can see her very good and beautiful face, Dr. Lilian. She's an MD, FEO. She's a uveitis specialist, Eye Institute at Cleveland Clinic, Abu Dhabi, UAE. Assistant Professor of Ophthalmology, Case Western Reserve University, Cleveland. So we can see now, we can go to our topics. So the first topic, it will be presented, as we mentioned, Dr. Mandeep. He's going to talk about steroid response to intraocular implant, beliefs, fact, and case scenarios. Then we will go to the Dr. Lilian to give the second part, which is about uveitis, and it will be this time infectious uveitis. So without any further ado, please, we can have Dr. Mandeep. The mic with you, please.
So can you see my presentation, Dr. Amri?
Yes.
And am I audible?
Yeah, you are. Everything fine.
Okay, from the onset, I would like to thank Dr. Amri and his team. I don't know how every week, every fortnight, they are able to manage to get us all together for this interactive sessions. Hats off to you, Dr. Amri. Very good evening, ladies and gentlemen. Very warm welcome to each and every one of you who have found out time today to join for this particular session. We would like to make it as interactive as possible. My special thanks to Allergan for sponsoring this particular session. So I'll move on to the topic. The topic today is steroid response to intraocular implants. So as an ophthalmologist, whether you practice posterior segment or anterior segment, in our careers, we have always come across this particular scenario. A steroid response to any kind of IOP response to any kind of steroid therapy, whether it's topical, peribulbar, or intravitreal, as in this particular case. Older studies and clinical data shows us the trajectory at which these IOPs in response to steroid spike. And we also know how to control them by using AGMs, whether a single AGM or two or in combination with other medications. So this topic is something we face day in and day out in our practice. It's nothing new. We know how to control this problem. We know how to live with this problem. But once in a while, we do have a patient which surprises us. So this whole presentation is going to weave around that particular patient, which I had in 2018 and 19. Which bothered us actually for almost 6 months to 9 months. So I'm going to basically present this particular case. Around this case, I'm also going to discuss the risk factors for branch retinal vein occlusion for our non-retina colleagues. We'll have a simultaneous discussion on the viability of steroid challenge test, a brief on the published data on steroid response, a snapshot from DHA data, and finally, I'll have certain questions which this patient raised to us. I would like to put it to the panel so that we can have a discussion, and I'd like to have views of the panel and the participants what they think about how we manage this patient. So this is our patient who is actually an extremely obese, let's say BMI of 42, an Afro-Arab lady who presented to our clinic to one of my colleagues in July 2018 with a drop in the vision 2.2, IOP was 14. So she diagnosed this patient as right eye inferior hemirectal vein occlusion, a very, very routine case in retina practice. She did all the investigations, the basic investigations that we do, and she managed the patients with intravitreal Lucentis on a monthly basis, serial Lucentis. Patient responded to the initial therapy very well. After 5 months, practically had a flat macula with vision improvement to 0.4. IOP was well under control. If you see, this FSZ is a bit enlarged, but that's because of the ballooning, persistent ballooning, not because of ischemic maculopathy. She advised the patient to come back after 3 months. However, the patient presented to us in the emergency after 2 weeks, and that's when the patient landed up with me with a recurrent episode of hemirectal vein occlusion. So this patient had a recurrent vein occlusion. It's not a recurrent macular edema to earlier episode. She had a clinical picture which was replicating the first episode. All the hemorrhages were back and edema was back. So since this was a recurrence, I decided to go ahead and investigate her systemically. FFA was on my mind, but our cardiologist didn't allow me to do that because in his examination, patient had a sinus rhythm and tachycardia, a postural tachycardia. He wanted to investigate cardiologically a bit more, so he was a little apprehensive. So we decided not to do FFA. We discussed the Ozurdex as an option because next month patient was due to undergo pediatric surgery, and she was actually booked for the surgery in one of the governmental hospitals. I was expecting not to see this patient very frequently as we do with our routine patients, and I thought Ozurdex will be a better option. During her investigation, which was partly done by me and partly for her pediatric surgery, we found out that her HbA1c was a bit deranged. She did not have any diabetic retinopathy in either of the eyes. It was just a vein occlusion. We also found that CRP was high, complement C4 was high. She had fibrinogenemia. On protein electrophoresis done by my general surgeon colleague, we found that the patient has increased gamma globulins. And one of our investigations revealed that she is actually having proteinemia S. We generally screen patients for protein S and protein C deficiencies. But contrary to this, I was surprised that this patient has hyperproteinemia S. So again, coming back to a bit basics, the published data which relates recurrent vein occlusions to different risk factors. These are the risk factors. I've also listed which risk factors actually existed in my patient. BMI was high, and it has a very strong correlation in patient developing a recurrent vein occlusion. She had arterial hypertension, diabetes, yes, hypergenemia, hypergammaglobulinemia, and she had sleep apnea, obviously because of obesity. She also had G6PD deficiency. Now, incidentally, G6PD deficiency is actually protective against vein occlusions, not to be in this particular patient. So before we decided to go ahead with Ozurdex, I decided to do a steroid challenge for 3 weeks for this particular patient because, as I said, I was not expecting this patient to see after a month or 6 weeks after the injection of Ozurdex. So I wanted to be sure that she doesn't have a steroid response. But as we know very clearly from the previous studies that steroid challenge does not weed out steroid responders sufficient enough to prevent sufficient IOP spikes. We also know that a negative response does not guarantee that there will be no response when subjected to steroid therapies. Anyways, since I couldn't do a FFA, this was a recurrent episode, I decided to go ahead and do a sectoral laser for this patient and gave her an IV Ozurdex on 20th of December 2018. Unfortunately, for some technical reasons, her pediatric surgery got cancelled, and this patient came to me with a bit of redness 2 weeks after the injection of the implant. This was the time I recorded the IOP as 34. To my surprise, in my career, I had never seen a patient with response to dexamethasone implant presenting 2 weeks after the implantation. So generally, we see patients anywhere between 6 to 8 weeks, and this was a real surprise for us. I took an opinion from my glaucoma colleague, and we started the patient on double medication. I'll just rush through the timeline and see how this patient fared. After a week, patient was maintaining IOP of 18. That's good. She comes back a week later with IOP of 34 on double medication. If you see, her maculopathy was resolving, vision was improving. That part is fine, but IOP was increased. So we decided to put the patient on triple meds and Dimox. In the next visit, when we found that all the 4 medications are not effective enough to drop down the IOP, we decided to have a discussion on trabeculectomy for this patient. For some social reason, the patient denied to undergo trabeculectomy because one of her friends had an issue following trabeculectomy, and she presumed that she will go blind with it. She was okay with anything else, but not trab. So running out of options, what I did is a week later, since IOP was not reducing, I decided to go in and do a limited vitrectomy and remove the implant. Following this vitrectomy, I don't know whether this picture is clear or not. This patient had an IOP drop, partially because of the decompression effect. There was shallow choroidal detachment, and that is the reason I stopped AGM. 1 week later, she comes back with IOP of 26. She was again on triple meds, and then IOP goes again high to 40, and then we tell her that we have to do trab, and she vanishes. She comes back to emergency 3 weeks later with a third episode of hemiretinal vein occlusion, all hemorrhages, edema back. We are back to square one, this time with high IOP. We've practically forced the patient to go for trab this time, and we did trab with mitomycin C with eflibercept. So if you look into the timeline of how IOP spikes happen in this particular patient, 2 weeks, she presented with 35, responded initially, then again the IOP spiked to 35, responded to vitrectomy, rather decompression effect. Again, the IOP went back to 40, and finally we had to do trab to control the IOP and macular edema in future. This was a bit of surprise, as I said, because when you look into the data published by MEAT trial, the IOP spike was, the patients presenting with the IOP spikes was generally in the second month, 7 week as a mean. And very, very few patients, or practically no patients in this cohort actually presented in the second week. The good part with the MEAT trial is it tells us, it differentiates that which patients are going to have a steroid response and which ones are not going to have steroid response. Also, the MEAT trial tells us that once you have steroid response, how you want to deal with the patient, what kind of spike you're going to get. Is this patient going to get control with AGMs or not? And there were almost 20% of the patients in MEAT trial who were kept on AGMs for 3 consecutive years, while a serial Ozurdex was implanted to control different kinds of macular edemas. So that there is a kind of predictability which our patient was not following. If you look into the SOFADEX study, which is the classical study to look into steroid response in 1,000 implants in 421 eyes, a similar numbers were projected. Almost 27% of the patients presented with more than 10 millimeter of mercury spike in the IOP. A mean time of recognition was 60 days, which ranged from 8 to 88 days. Now, in this cohort, there were only 2 patients. One presented in 8 days and one presented in 18 days who were like early presenters. Both these patients had prior history of glaucoma and were on treatment with glaucoma, and both required to undergo trab procedure later on. So we can kind of conclude, if the patient presents with such a huge big spike so early, most likely this patient would require a trab in the due course of time. Data in DHA with 104 eyes in 3 years of this duration showed us that 12 of our patients out of 104 eyes which were injected with Ozurdex, just one Ozurdex, I'm not talking about follow-up Ozurdex here, had IOP more than between 20 and 25. 6 patients had IOP between 25 and 35, and 2 patients, one of the case that I discussed, had IOPs more than 35, and only this patient required trabeculectomy. If you look into the classical data of some of the other steroid implants and steroid components which you have used to treat DMEs, Retisert implant in certain studies had 77% of the patients who came back with IOP spikes. 37% of these patients actually required filtering procedures. However, there is a bias. Retisert was generally used for uveitic eyes. Similarly, in intravitreal triamcinolone acetonide injections, the TRAB rates actually range from 1% to 7% in different studies. When you look into the modern implants, if you compare fluoromethalone long-term implant, the initial FDA study showed the trabeculectomy rates as close to more than 4%. The real-world data shows it little less, but it still ranges from 0.7 to 5%. Dexamethasone implant, on the other side, have got trabeculectomy rates documented from 0.1 to 1. So if you are really bothered about which is the best implant to go in terms of steroid response, you're worried about it, probably dexamethasone implant wins the race. Coming back to our case, this is how we eventually managed her. We went ahead with serial anti-VEGF therapy again, and this is how our patient fared. Not before she actually projected certain important questions for us to answer. Is there any role of steroid challenge test in our modern day practice? Are there still unknown factors that we don't know while gauging a patient whether he can or he cannot have steroid responses? Was I right in removing the implant? And if you have a successful, let's say if this patient has a filtering bleb at this point of time, would you consider injecting this patient with another Ozurdex implant? So, Dr. Amri, I would like to take you to take it from here, and we can discuss the case, the questions in the forum. And at the same time, I would like to thank everyone and all the attendees who have found out time to come here tonight. Thank you very much.
Thank you very much, Mandeep, for this excellent presentation and sharing with us this case. I think it's rare, but it can happen. So I think you have done all what you can do to solve the problem. I don't know if there is any opinion. We can take Dr. Lilian, also she is an expert, and Dr. Iman also, their opinion. So if you face, first of all, Dr. Lilian, cases like this before, something you reach to do a trabeculectomy?
I mean, I have never faced a case that was needed to remove the implant because of the pressure, because usually the patients, they allowed us to proceed with the glaucoma surgery if needed. I think for you, the difficult here was to manage the pressure because you were limited. Patient refused the surgery, so you have to do something. And I guess it's important to address this possible scenario when we are discussing the difference between injecting anti-VEGF and injecting steroid implant. And I had a patient that he responded very well to Ozurdex, very well in terms of anatomic resolution, very well in terms of improving vision, no spike in intraocular pressure. And when I moved him to the fluocinolone implant, he spiked. So again, is there a role for the test? Because he was not raising the pressure under Ozurdex, and he did in the next implant.
Can we ask this, according to your scenario, Dr. Lilian, there is an accumulative effect due for steroid or not? I mean, the pathophysiology, it is not an accumulative. It is just a type of, I think, of steroid.
I think,
and blocking the trabecular meshwork.
Different molecules of steroids, they can interact in a different way with the trabecular meshwork, and we have to tell them, okay, if you did not raise the pressure with Predforte, this doesn't mean that you will not raise the pressure with Ozurdex, because we have prednisolone, we have dexamethasone. And this is and then it's not the same having something topically that's something inside the eye. So I guess this risk is always around us. And in my experience, my fear here is that patients, they don't come for the follow-up.
True.
So when you manage one or two cases, maybe you can call them, please come. But when you have a large population under treatment, you cannot be calling all of them, and they don't come to follow up. They come when the vision is getting worse, because we are approaching the median life of the Ozurdex implant. And if they are doing well with the Iluvien, well, good luck. When are you going to see them? So I think this is very risky, because in most cases, they are completely asymptomatic with very high intraocular pressure.
I think, but I mean, most of us, I think we are having our patient and they are coming for follow-up. The problem is that sometimes, even if you do the, as Dr. Mandeep done, and there is no spike of intraocular pressure, but after that, he faced it. So even so, your case also another issue. You have Ozurdex, then you have another one, and you feel there will be no intraocular pressure according to the usual way. This is unusual things that you will find a case that they are not having an increased intraocular pressure. Then after that, they will have. That's why it raises a suspicious. What is the reason behind of that? As we know, it is not an accumulative, it is not a synergistic, so we don't know who is going to have an increased intraocular pressure. But I mean, in general, with Ozurdex or fluocinolone or whatsoever, the percentage is very, very low. I mean, it's I have so many years using steroid. There is people, they are having increased intraocular pressure, but they are very, just between 20, 25, maximum 30, as Dr. Mandeep mentioned, and they are treated with one type of anti-glaucoma. But we didn't reach to a certain area that we are having non-responding, and they are more spike, and they are having a very high, more than 35, so we can, and not responding to 4 type of different anti-glaucoma, so we can go for a surgery. I think what it was seen in the study is completely different than a real life practice. This is my opinion. I don't know, maybe you can agree with me, or if you have something different, let me listen to your opinion. Mandeep?
No, I totally agree with you. In fact, coming back to the trabeculectomies, when we have discussion with our colleagues, most of these patients who develop this kind of steroid response are the ones who are already known glaucoma patients. Now, trabeculectomy failure rates are extremely high in these patients, because you have got scarring of conjunctiva and because they've used AGMs for long time. So there is also a discussion whether you should go into a traps or directly go for tubes. I mean, that's a part for glaucoma colleagues to look at. But when I went and had a discussion that this patient has an edema and it has responded pretty well to everything, can we go in and have another Ozurdex implant? And he was like, no. Okay, let's see whether the trap works. I don't want to subject this lady to another procedure. And but I guess it's not an absolute contraindication. It's not an absolute contraindication. Once you have a filtering trap, you can go in and inject an implant. That's not a problem. But in practice, would you do that? That's a big question mark. Would you do that? That's a big question mark.
I think, if you want to put the things in the proper way, Ozurdex or steroid, they have a rule to treat many of macular edema, either related to diabetic macular edema or related to branch or branch vein occlusion. So we don't want to be a hesitant to use this medication because we are afraid of 1% or even less than. You are having how many cases you show, and they are all within the range that you are managed or able to manage them easily. But you face someone which is okay. So it's we don't want to concentrate on a very minor things or very, very rare and forget the benefit that we are have to use it, especially when we are actually have a problem even during the COVID era, or even those they are in compliance patients. So you need to find a solution for them, instead of you can just forget them and they are coming to take one injection, then you will lose the follow-up for 5-6 months. In your case, it's have 3 times. Even they are, you can say, even they are compliance patients, but they are having this problem. But so I think we have to concentrate on the positive things. Yes, we have to talk about there is some complication camp, but it is a very, very minor, and shouldn't keep in our mind that it's a contraindication unless something we reach to, like your case. So we have to discuss. And I have listened to one of my friends. He said, you can do your job and then transfer the patient to glaucoma. Let him deal with his work. Dr. Iman, if you have any comments from your side regarding, because I know you are having also an experience in that.
Thank you very much, Dr. Ami, for the kind invitation, and thank you, Dr. Mandi, for the experience you've shared with us. Actually, my opinion is that there is a racial difference in the response of the patients to trabecular meshwork to steroids in Egypt. They do have a tendency to get an increased intraocular pressure with steroid use. I believe more than the United Arab Emirates. Our people usually get a rise in the intraocular pressure after trimethinolone injection or Ozurdex or Iluvien, and even with steroids, topical steroids like prednisolone, dexamethasone, or difluprednate. The ratio of steroid-related glaucoma and optic neuropathy is very high. This might be affected by a referral bias because I only see tertiary cases. I receive cases who have visited several doctors and maybe undergone several surgeries, and then they are referred to me. So there might be a referral bias in the incidence of complications. But the patient will be injected even one short steroid, not an implant, come with a glaucoma and an optic neuropathy.
Dr. Iman, we are missing your voice. There is an interruption, maybe the internet. I don't know. It's my side or Mandeep and Dr. Lilian. Can you? There is some interruption in the. Yeah. So I think, Dr. Iman, we received your idea about that. But I feel it is maybe there is something also to explain that. I don't know. I cannot tell about what is the percentage, but this one also, I think in Egypt, they are mainly using what we call not an implant. Most of the time there are some places maybe they are using what we call
Triamcinolone.
Triamcinolone. So it's very high concentration, and it's mainly more higher and higher percentage of having the increased intraocular pressure. And also the follow-up, if they are lost follow-up and came after a while, maybe they will have these complications. This is my, I think, explanation. Otherwise, I don't think there is a special race difference. I didn't hear about that. But also maybe the high number of population make the percentage a little bit different, because in Egypt is completely, we are 8 million in United Arab Emirates in comparison, or 10 in comparison. Maybe this only in one area of Cairo. In Egypt, there are over 100 millions. And if you want to visit Mandib in India, it will be 1 million, not 1,000 million. So thank you very much for this feedback. Just we are having two small, I think, questions from one of our participant, Dr. Ashraf Awaja. He is asking Mandib, it is paraproteinemia or it is gamma globulinemia? I don't know.
It's gamma globulinemia. That's the reason we did electrophoresis, and it was the only spike was in gamma globulins. There is no iris rubeosis.
And okay,
There's
so
no
you get
NVG.
the answer. Thank you very much without question. So now we can move to our dear colleagues, Dr. Lilian, and to give us a talk about infectious uveitis. We will enjoy her talk now. Dr. Lilian, the mic with you, please.
Can you see the screen?
Yes, yes, please. If you can make it, I think in a slideshow.
Yeah, wait. I'm trying to do that now. Now.
Yes.
So thank you very much, Dr. Mohammed, as always, for the kind invitation, and thank you, my colleagues and the people who are attending so late in the night. So when I thought about this talk about infectious uveitis is such a wide field within uveitis, and whenever we study or read about infectious uveitis, the chapter or the talk starts with the title. Let's say toxoplasmosis or toxocariasis. So we know what we're talking about, and we describe the features of a disease we know in advance that we are going to cover. And the situation is completely different when we are facing patients in our practice, because they come to us with sometimes very few things and no title. And it's on us to catch these few elements that maybe we have, because the clinical picture we see in our practice is not the same as it is described in the books, and by the end it's on us to put the title for the disease. So the idea of my talk is to start with a case without a title and get the title together by the end. I hope you will enjoy, and without further ado, let's get started. So I cannot, yeah. So meet the patient. This patient came to me in 2017, and keep in mind the year, because you will see it has some importance in the context of the patient. She was by that time a 43 years old female. She was otherwise in good health, and came to me because of blurred vision in her left eye for 1 week. No pain, no redness. Everything was fine. The only important personal history was delivery of a girl, a baby girl. She was in good health, and this happened 2 months ago. And she told me, you know, after delivery, I got sick. I have a severe infection, and I was managed successfully with antibiotics. And this was the only information I had, because she delivered in another facility and we didn't have reports. So I said to her, next visit, bring me the reports, but this was the only information. Going to the examination of the eye, her best corrected visual acuity was 20/20 in the right eye and 20/30 in the left. This was the eye she was complaining about a blurred vision. So a small decrease in visual acuity. Intraocular pressure was normal in both eyes. The difference between the right and the left is more than 2 millimeters. So this is also maybe related to inflammation, but it was normal. There was inflammation present in the anterior chamber of both eyes. 2+ cells in the right eye, 3+ cells in the left, no keratic precipitates in either eye. And about the posterior segment examination, she had 1+ vitritis. That means there was inflammation present, but we were able to see the features of the fundus. And this was the fundus examination. We can see in the right eye a very well preserved foveal reflex. The right eye is the eye with 20/20 visual acuity, but there is a small white lesion I hope you can see how I'm pointing towards it. Round seems superficial in the retina, and in the left eye, the eye she was complaining about, we can see some hyperemic of optic disc and a white lesion parafoveal within the arcades at the macular area. And at the periphery, you can see here these tiny hemorrhages. And again, there is some inflammation of the vitreous. You can see for some vessels, you cannot follow them entirely, but still is not a very important vitritis. So this is what we had for her, a decrease in visual acuity and 2 lesions in the retina of each, one in each eye. So I did for her in the first visit a fluorescein angiography. Here you have later frames, and you can see that they are hyperfluorescent. And in the right, in the left eye, there is mild leakage from the lesions. So this is all the information we have, and we have the patient in front of us, and we need to think about what's going on here in order to tailor our investigations. So I ordered some blood tests, were very non-specific, sedimentation rate little bit elevated, CRP little bit elevated, but this is non-specific, and she delivered 2 months ago, before this episode. So we have a young woman. So far, she's immunocompetent. I don't have any clue for any immunodepression at this point. And she has bilateral retinitis. We have 2 small lesions at the level of the retina in both eyes. Is this going to be infectious in nature? Is it going to be non-infectious? Well, we are in a session of infectious uveitis, so you can say, okay, if you're presenting here, it's going to be infectious, but I didn't know that by that time. So, can this patient has, for example, toxoplasmosis? I don't know why, but whenever we see something at the retina, toxoplasmosis comes to us as a diagnosis. And okay, toxoplasma retinochoroiditis is one of the most frequent causes of posterior infectious uveitis. So why not to think about toxoplasmosis? Toxoplasmosis is a retinochoroiditis. This means the lesion starts at the level of the retina and then will go through the choroid. And how we see usually toxoplasmosis? We see the lesion as a white area of retinitis, like you see here, close to a dark scar. And this is not the case in our patient. Why we see this configuration? Because most commonly, when we are facing all the patients with toxoplasmosis, we are seeing a reactivation. So the black area is the old foci, and this is the new one. You can say, okay, maybe your patient was not having a reactivation, but a primo infection from toxoplasmosis. And this might be true, so we cannot 100% exclude toxoplasmosis. However, how common is to have bilateral involvement in toxoplasmic retinochoroiditis? If I ask you, how many times have you seen patients with 2 lesions, one in each eye, active at the same time? It's quite uncommon unless you are dealing with congenital toxoplasmosis. Congenital toxoplasmosis is bilateral in around 80% of the patients. But when we see patients with congenital toxoplasmosis, we see already a big scar, usually located at the macula because of the high level of oxygen that the macula is having during the intrauterine life. So we don't see usually an acute inflammation. We see 2 scars. Acquired toxoplasmosis in the immunocompetent host is usually unilateral. It is usually unilateral, but it is not always unilateral. And this is a very interesting report. It came out in 2021, and it's describing bilateral ocular toxoplasmosis in a returning traveler. And for me, was not a surprise, but it's interesting, this title of returning traveler. The patient was from the UK, immunocompetent, around 60 years old, and he was returning back to the UK after a 3-week cruise around Brazil and Argentina. You know, I am from South America, and for us, it's not unusual to see bilateral involvement, simultaneous bilateral involvement in ocular toxoplasmosis. And this is related to the parasite strain. The parasite strain itself is a risk factor for severe or atypical ocular toxoplasmosis. There is a strain-dependent difference in cytokine expression, and this is correlated with disease severity. And it has been shown that the South America strains are related to more severe ocular toxoplasmosis. So whenever you are facing something you do not understand, keep in mind to ask, have you traveled recently? This was not the case in my patient. Then, toxoplasmic retinochoroiditis is a granulomatous uveitis. And I told you at the beginning, there were no keratic precipitates, and I didn't describe any iris nodule. So again, she's immunocompetent so far. We can say the inflammatory response depends on the host immune status. Of course, here you have a picture of a highly inflamed vitreous with a wide area of retinitis. This is the classical clinical picture of toxoplasmic retinochoroiditis in the immunocompetent host. So we have a very important response at the level of the vitreous with a lot of inflammation. On the other picture, you can see that the fundus is very clearly seen because there is no inflammation. And you have a large area of something, a white area. So this is a white area on the retina. This is a retinitis with some hemorrhages, some laser spots besides it. And I can tell you this is also a case of toxoplasmic retinochoroiditis, but this is going on in a severely immunodepressed host. So there is no way for this patient to have a proper immune response. So are you expecting in this patient to have granulomatous keratic precipitates or iris nodules? Of course, no, because in order to have that, you need a normal immune system. So whenever you are facing a posterior uveitis, infectious posterior uveitis in the elderly patient or in the severe immunosuppressed host, you cannot say only by the clinical picture what's going on. And this is why it's so important in this particular population, aqueous humor analysis, which is not in the scope of this talk. But again, the inflammatory response for any infectious uveitis will depend on the host immune status. So we are not going to see always what it is described in the books, and we have to correlate what we are seeing with the immune status of our patient. But no one of these pictures is similar to the retinas I showed you at the very beginning. So probably this is not the case of toxoplasmic retinochoroiditis, and this was my thought with the patient. Can this be a case of a viral retinitis? We have two small foci of retinitis, one in each eye. Can this be viral? Well, if you have ever seen acute retinal necrosis, which is the affection of the retina by a herpes virus in the immunocompetent host, this is one of my patients, and you can see it's very difficult to see the retina here. We can see these very large areas, confluent areas of retinitis at the peripheral retina, but even with very flu borders, but we cannot see the details of the retina. And again, this is related to the severe inflammatory response in the immunocompetent host. And this is part of the definition of acute retinal necrosis. Again, this is a granulomatous inflammation. And again, this is not very similar to what I have shown you at the very beginning. What happens if the herpes virus is affecting a patient without a proper immune response? Well, we will have very clear access to the fundus because there's no vitritis, and we will have these very large and confluent areas of retinitis that they are rapidly progressing from the periphery to the center, and this is the typical picture of progressive outer retinal necrosis, which is the counterpart in the immunodepressed host. The other clinical picture you will see with the viral retinitis in the immunodepressed host is CMV retinitis, cytomegalovirus retinitis. Same, you have a clear view of the fundus details because there is no inflammation. There are no cells precluding you from a clear view, and you have a large area of retinitis, but very hemorrhagic retinitis. You can say, okay, the patient had hemorrhages, but the hemorrhages I show you are completely different, are 2 or 3 dot blood hemorrhages at the very peripheral area. So I dubbed my patient is having a herpetic retinitis. So what's going on with her? Because now I show you things that probably they are not the diagnosis, but we need to find a diagnosis for this patient. I'm showing you here the left eye, which was the eye that was mostly affected, and see here the small lesion of retinitis. So we did an OCT. Keep in mind this was 2017. And this is the OCT going through the lesion. You can see that the lesion seems to start at the level of the choriocapillaries. Then over the choriocapillaries, there is a interrupted RPE line. So the RPE is somehow involved. And then you have a full thickness retinal involvement, and it has the aspect of going from the choriocapillaries to the vitreous in a centripetal fashion. You can see here different cuts over the lesion. See here this area that is pointing towards the vitreous. And again, this was in 2017 and helped somehow to get into the diagnosis, but very interestingly, here you have more images. Wait a minute, I wanted to explain you. Again, you have here the lesion in this area, and you can see here the vitreous involvement. This is vitreous inflammation, the cells, and the cells are like condensed around the lesion in the left eye. And I did this circle here to show you this white area here that has very homogeneous reflectivity and produces this echo and this shadow here, and we cannot see the retina underneath. So again, this is going to be very helpful in our diagnosis. The right eye was the right with better vision, but if you go with the OCT through that small peripheral lesion, you can see similar features. There is some vitreous involvement. You can see here vitreous cells. You can see here thickening of the posterior hyaloid membrane. And this lesion I described in the previous slide with choriocapillaries involvement, disruption of the RPE line, full retinal thickness involvement, and this image that the lesion is going from the external retina or from the choriocapillaries towards the vitreous cavity. And here again, the inflammation. So this helped arriving to the diagnosis, but it was very interesting that in 2018, 1 year later, there was this article in Retina describing the spectral domain OCT findings in endogenous Candida endophthalmitis and their clinical relevance. And the authors, they described two patterns of OCT changes. One is the chorioretinal pattern I described to you, a full thickness lesion spread and going from the choriocapillaries towards the vitreous. And this is mainly showing the spreading pathway from the choriocapillaries to the vitreous cavity that Candida is following. And this is the most common way for Candida to arrive to the eye, from the bloodstream through the choriocapillaries towards the vitreous. There is another pattern which is less common, and I didn't see in my patient. It is called intraretinal pattern, and in this particular pattern, you will see partial thickness lesions sparing retinal structures beyond the inner nuclear layer. So your lesion will be at the level of the inner nuclear layer and towards the retina and the vitreous. And this happens mainly because the spreading pathway of Candida is from the proper retinal vasculature. Candida is getting into the eye from the retinal vessels, not from the choriocapillaries. So this was very interesting to me, but it came late. But it's true that these lesions in the OCT help us thinking about a fungal infection. So my patient was started empirically on oral voriconazole and intravitreal injections of amphotericin B. There was a diagnostic vitrectomy being performed, and the vitreous culture was positive for Candida albicans. This is a recent OCT scan, and I can tell you she recovered very, very well, and her visual acuity was excellent. And this is described for Candida. Candida albicans usually has excellent outcomes, mainly because of this predisposition to go towards the vitreous cavity. Other fungal infections, they go more through the retinal structure, and they are more deleterious in terms of final outcomes. For Candida, you have the chance to remove the vitreous and to treat the vitreous, and the outcome is going to be better. Although, I have to say, with the chorioretinal pattern of infiltration, there will be a scar, and this scar might somehow preclude complete visual recovery. So, endogenous Candida endophthalmitis is a diagnosis to keep in mind. Candida albicans is the most common fungi causing endogenous endophthalmitis. Predisposing conditions for getting this infection are mainly prolonged hospitalization, major surgery, diabetes mellitus, malignancies, catheters, use of intravenous drugs, HIV, immunosuppressive therapy, but can also occur in otherwise healthy subjects. Okay, my patient, she told us she had an infection after delivery, so maybe it was related to this infection, but she was not in severe disease. So keep in mind the diagnosis whenever you do not understand what's going on with a particular patient. Disease can be very difficult to diagnose in the very first stages, or during a prolonged and indolent course, or in a patient without significant risk factors. And in these cases, we know that OCT has a very important role, because you can see these kind of lesions that are highly suggestive. Keep in mind that Candida will always grow towards the vitreous, and this is different from other kind of fungal infections. So even these OCT features are pointing towards the etiological gynecologic diagnosis. It has a better prognosis compared with other fungal endophthalmitis. And as I said before, chorioretinal pattern of dissemination of Candida will produce a scar, and this scar might limit visual recovery. And for you to take home messages, always have a patient-oriented approach. When you are seeing your patient, at least put in mind 3 differential diagnoses more, because my other differential diagnosis for this patient was Behçet, and I excluded it. Try to do a very tailored ancillary test, because if you order a lot of tests, you will get confused, because you can have positive results that are actually not related to the disease you are managing. Do more and more images, see how important was OCT in this patient. And if you are in doubt, don't forget to go promptly to ocular fluid analysis, which has a very, very important role in infectious uveitis. Thank you so much, and I am ready for your questions.
Dr. Karina, this is a very, very, very excellent way of presentation. You know, not up to my expectation. Thank you very much. You take us, you rotate us well. I was concentrating a lot behind to know what is going to happen. I was, very nice. Thank you very much. It was really
my pleasure.
Amazing way of presenting with this case. I was thinking, so it will be a toxoplasmosis. Then no, it will be it will be PMD. No. Then you put us at the end in somewhere else. But really a very nice case, very interesting way, very good presentation. I like it very much.
And the good thing is that patient is still with me, even though it was very difficult for me to get a diagnosis. And she saw me very confused. And I said many times, I don't understand what's going on. I don't understand. And we are still together. And her vision, the last time was corrected 2025. So the outcome was very good.
I want to know, after how long you reached to the diagnosis?
No, it took, because I just show the very first pictures, but she deteriorated because these lesions, they went towards the vitreous. So once they went into the vitreous and you can see the classical white fluffy balls, you say, okay, this is a fungal infection. So that is easy. I think it took like 1 month. When we decide, okay, let's try empirical treatment, and one of my colleagues in retina perform a vitrectomy.
Okay, so after 1 month only, then you reach to diagnose.
Yeah.
It's a short period. I mean, for me, I was thinking you will tell me 1 year after.
No, because it's progressing. I mean, you are not understanding what's going on, but the candida is evolving, and when you have more lesions, then you say, okay, this is it. But you do not expect this kind of disease in a patient that is knocking the door of your consulting room. You expect this in a patient who is admitted. And this was not the case, because even though she had problems at the time of delivery, she recovered and she was perfect. The only problem was the eye.
I think, I will repeat again. I mean, I was very impressed by the presentation. Actually,
don't be shy. Say I don't know.
You cover all the different way. There is only maybe tuberculosis. We didn't hear about it. I know it can lead to some sort of infection and bacterial, but the others, viral, fungal, and the most common, toxoplasmosis, you cover it in a very nice way. So also we are having a very, very expert uveitis, Dr. Iman, and we need any comment from her side. Dr. Iman.
Oh, thank you so much for the excellent presentation. I totally agree with the diagnosis of candidiasis because we've seen it very frequently, especially with the gynecological and urological infections, even if post-healing, even if the infection has gone away. Thank you so much, and I totally agree with the diagnosis.
Okay, Dr. Mandeep, you want to say something before we go to the questions?
Yeah, very well presented, Dr. Lilian. And really, as Dr. Amri said, it was a swing. All the while we were thinking it could be this, it could be that, and it turned out to be something else. But I will play.
She play with our mind. She play
Yeah,
us.
she played with our mind.
Take us.
Exactly.
Yeah.
I just want to play devil's advocate, take you back when you were actually, let's say we don't have the diagnosis and you are still working on this patient and you are not sure what it is. So certain points, just trying to get the links. When this patient had this issue with after gynec surgery, did you look into what caused this illness after the gynec procedure?
I will say, if you have no clue, the important issue was this problem at the time of delivery. So we should get as soon as possible a report from the hospital.
Exactly.
This was in 2017. We were less integrated in terms of dealing with different hospitals. I think now is much easier, but you ask the patient, please go to your doctor, bring me a report. And it's not something that is coming the next day, unless the patient has a direct way to talk over the phone with their doctors. And then I put myself in that situation in 2017. She was a mother with a very little baby and 3 more kids, and she was tired about all what happened before with the delivery and now the eye. So it was not easy to manage the patient, the person. I remember she was coming with a friend, and sometimes she was depressed, and she was telling me I will end blind, because after delivery there are a lot of emotions related to hormones. So I didn't push her enough for that report. But that is the thing. I think the answer is there. What happened maybe it was not an infection related to candida. Maybe it was a bacterial infection, and they put a catheter, and then through the catheter she got candidas from the skin. This is also possible. Keep in mind that during pregnancy there is a relative immunosuppression. And
absolutely. Yeah. So when I looked into your FFA, the left eye, the leak doesn't appear homogeneous. You can very clearly see that you have a non-leaking area, and on temporal side you have a leak. So it is very misleading, especially on optos, because you will immediately think, okay, fine, this is toxo.
This is toxo, exactly.
Exactly. And you need to look into what that lesion is, and that was not a scar, that was actually that white fluffy thing, which was a component of candida infection.
Toxo, because in toxo you go from the retina to the choroid, and here it was coming from the choroid towards the retina and the vitreous.
And again, toxo can have present bilaterally, especially after pregnancy and delivery. I mean, there are case reports, because pregnancy is a condition which can alter the...
many cases in Argentina, especially people who were coming from the north of Argentina, which is the border with Brazil, because north of Argentina and south of Brazil, we have these aggressive strains, and you can see bilateral involvement in immunocompetent host.
So when this confusion was persisting, whether it's candida or something else versus toxoplasmosis, you didn't feel like starting this patient empirically on anti-toxoplasmatic therapy? I mean, because, a month is good enough for the whole lesion posterior to wipe out.
My big fear was to be missing a virus, because by the end of the day, toxoplasmosis will show up to me and the lesions were not so close to the fovea. My fear was most a virus. I was like, maybe I'm seeing the very early stages of a virus, and then in 2-3 days it will come in a way that I will not be able to control. But I have to say, this question is very easy to answer, because you take a sample of aqueous humor and you can do toxo and you can do the viruses. Of course, you can do more, but you need to ask for more.
Yeah.
Toxo and viruses is the thing we do in the common practice. But for the fungal infection, you need to think about that.
If you allow me, I want to ask Dr. Iman also. Dr. Iman, if you are in the position of Dr. Lilian, what is it came to your mind without knowing the diagnosis? What was the first impression that it came to your mind from her presentation or case?
Well, the most common scenario in Egypt is following any urological or gynecological event or infection. Usually, especially in females, we are directed towards candidiasis as the top of the list possible diagnosis, especially in females.
Okay, is there any test that you want to do? So maybe Dr. Lilian, she depend on, maybe she didn't mention everything because it's very difficult to bring all the information at what haven't done with the patient. But if you are the one, if there is any test that you want to do, for example, blood test for any or systemic things that it can show or related, because this also some question came from our attendees related, they are listening to us to show this is a fungal or this is to exclude a fungal or
in our practice, usually a blood test is not whether a good positive or a good negative for fungal infection of the eye, because the eye volume-wise is not very well represented in the bloodstream. But we do test routinely for tuberculosis and syphilis because of the fact that they are great masqueraders and they can mimic any possible picture, and because we do have a resurgence or a re-increase of TB in our country, so we test for it routinely in any case.
Okay, Dr. Lilian, did you do any test for syphilis? Because
well, yeah, it's part of the basic lab in uveitis, syphilis and TB. Because even if you have, let's say, Behçet disease, and you need to put the patient under immunosuppression, you need to know if you are having a concomitant infection that maybe is not related to the clinical picture you are seeing. But once you put your patient either in high doses of cortisone or in immunosuppressant, this will create a problem. So I think this is basic for every patient.
I think it was covered nicely, and thanks for this excellent presentation and discussions, Dr. Mandeep and Dr. Iman. And I think most of the questions or comments that also sent in the questions, it is already we answered it indirectly with our discussions. Thank you very much for this really a very nice meeting, webinars. I was enjoying the lecture of Dr. Mandeep and Dr. Lilian, and enjoyed the discussion with Dr. Iman as usual, learning from her experience. Thanks for all participants. They are with us today. You know, it's not a weekend as usual because this time we need to do, and we have to finish some episodes before we come to our Eid. So our next meeting, it will be on this Friday after only one day or so in 1st of July, and it will be a medical retina series. I would like to invite all to be there. Then after that, we'll take a rest for 1 week. Then we'll come back on 16th of July. For those they are not having or they are not able to get the certificate, please contact us through either the Facebook or the LinkedIn or the Instagram. Just send your message with your name and your email, and there will be someone who will reply to you. Now, just management, they upload now the link for today's certificates. Please, you can stay and they will not close. So you can just look, and you will find it also available in all our social media for 24 hours. So you can upload your certificate. At the end, I would like also to thank Allergan AbbVie for their sponsoring this meeting, and we hope to see you inshallah very soon. Thank you very much for all, and good night. Thanks a lot. Bye bye.
Good night, Dr. Good
night. Bye bye.